So it is a big challenge, but that would be a good lesson, I think, for those looking for a job in any field as the applicant, is to be really clear. And if they can't answer that question, if you're interviewing with a practice manager and they can't answer, I don't know how we're going to support you. That's a big red flag.
So welcome everybody to the What Not to Do in Your First PA Job series. We are very fortunate today to have with us Jason Astrin. Jason is the Director of APP Services for the U.S. Oncology Network and does a tremendous amount of work around community-based oncology practices. So I'm really excited to have you with us today, Jason. Thank you.
Great. Thank you, Deborah. Happy to be here.
So let's start with your journey into becoming a PA. Tell our viewers about your specific story.
Yeah, great. So I kind of stumbled into the PA role, like probably a lot of people my generation did back in the early 1990s. There wasn't a huge calling for PAs in our healthcare environment. The numbers were growing, the programs were developing. Mostly everybody that was close to me, family and friends, had no idea what a physician assistant was. A lot of them had never seen a PA at that point. So, however, I was training in the military to be a lab tech, really just to develop, GI Bill opportunities and money to go to college, and not really sure of what I wanted to do with my life. When I was training in the lab, which was in hospital and clinic environments in the military, who always had a strong presence of PA activity, I met my first PAs and realized, well, that's an interesting career, and spent time kind of shadowing them and asking them questions and trying to discover, what is it that you do? Why are you different than a physician? How are you different than the nursing side? And decided at that point, while I was training in the lab, to kind of pursue PA education and maintain that through the military. So I attended the Army PA program back in the early 90s, when the military branches all had their own individual PA schools. Several years ago, they all combined into an inter-service program. So all of the branches kind of train together, and then they do clinical years kind of at more branch specific. However, my program is still Army focused, which is heavy primary care, internal medicine, and a lot of trauma. And so spending time with Army PAs, spending time with other PAs that I knew in the community while I was training, just really kind of sealed the deal for me. And I was happy that I chose that program and pursued that education. And people would ask me throughout my career, and I graduated in 1995. So since then, working in clinical and non-clinical environments, people, friends, patients, whomever would constantly want to know, would you do it again? Are you happy in your career? And I always say yes. I would exactly train again. I would do exactly what I did if I had to do it all over again. It was a great career choice, and as I think as most of the listeners are going to agree with as well.
And I love that story. And so I'd imagine, like you said, in the Army, what you were doing, you were exposed more to primary care, trauma. So how did you find your way into oncology? Did you start in that? Did you start more in primary care and maybe emergency services?
So the good thing about PA training is that all PA programs, right, have to follow a similar blueprint on what they provide from an education and a clinical perspective. And so the Army program was no different. We were affiliated with University of Oklahoma. I actually had to apply to the University of Oklahoma program and to the Army program simultaneously, and had to get into both to then attend that Army program. And so the training, even though the use and utilization of a military PA is likely different than what a PA might do in the non-military environment, the education and the background is the same. And so we still had plenty of education around internal medicine, subspecialty, surgery, our clinical, in my clinical year, so of course, back when I trained, it was typically a 2-year program. A lot of the schools today are 3, some are longer. And so the second year was really devoted to clinicals and just patient care and exposure. And we did a lot of rotations in a lot of different specialties and still had the same kind of well-rounded education. So we came out kind of with the same level of intelligence and experience as probably, any PA student would. And what's nice about, I think, and a really good advantage about attending a PA program is that when you do graduate, you do have kind of a wide open field of choices and where you want to practice, and having that flexibility and that mobility to shift around, I think is very important. I did spend my first 10 years in family practice on the East Coast in Western Maryland, and primarily because what they taught us in school and what I teach to my PA students that I interact with now is that, the 2 years or 3 years, however long your program is a good basic knowledge with some advanced key factors and key points from time to time, but there's still a lot more to medicine. Just like anybody who's practicing medicine, it's lifelong learning anyway, even beyond your education. And so my thought was, and what they kind of instilled in us in school, was to kind of continue that primary care, internal medicine type background, as build on that knowledge and those skills after school before you jump into like a super subspecialty. Which I'll add, back when I graduated from PA school, the majority of PAs were probably going into primary care, internal medicine, emergency medicine, or general surgery. And now we see a lot of shift where a lot of PA students have so much more options and a larger variety or wider variety of exposures clinically. And so they can wind up in a very small super subspecialty. And so I thought, in case I wanted to wind up doing that, I wanted to have a really strong foundation. So I was going to practice in family practice after school for sure. That was my plan, and do that for a couple of years, get a little more experience, see a variety of different patient types. And in family practice, of course, you're seeing newborns to geriatrics. I wound up staying there 10 years. It was really a good practice. It was, they allowed for a lot of autonomy. It was a big practice. We had a number of physicians, we had PAs, we had nurse practitioners, and I really took care of my own patients over those 10 years. I mean, it's likely and very likely that a lot of my patients I took care of only saw me, never saw anyone else in that office unless I was out for some reason. And so I stayed there for a number of years just because it was rewarding to kind of manage the whole family, and I was a younger provider when I graduated, and so I attracted that younger family, the new parents, the teenagers, and I spent 10 years like growing up with them at the same time. 10 years into it, I started developing actually an interest in cardiology. And so that was my first kind of specialty change, was going into a cardiology practice where it was hospital based, and I was split between the pulmonary side, which pulmonary critical care, interventional bronchoscopy, and the cardiology side. So I was a hospital employee and just kind of carried, both pagers. I actually had 2 lab coats, the cardiology lab coat, the pulmonary lab coat. I would change them in and out depending on what I was doing that day. I was the first PA that either the pulmonary practice or the cardiology practice hired. And then my pattern, and we can get into some of the details probably later, my pattern after that was I was pretty much always the first PA, just coincidentally. Maybe I sought that out and wasn't really consciously aware I was seeking that out. And so I had the extra challenge of navigating. We've never had a PA. What do we do with you? How do we use you? Where's the value in you? And so I got good over my career of kind of developing what that job description looks like, and did have some opportunity to practice in medical oncology during that time at that hospital that was in Baltimore City. And I remember the medical oncologist sitting me down. They had an inpatient service. Their PA that kind of managed that service had to leave for kind of an extended period of time. They didn't want to leave their service uncovered while they were in their office seeing patients. And the oncologist sat me down and said, I know you cover, the lung center, the heart center, you're covering the ICU. And I'm asking you now to help cover, medical oncology in these inpatients. And he said, it'll be probably, even though extra work and obviously, another pager to carry around, but it would be really like rewarding. And I remember him having this discussion telling me that this will be probably like the best several months, of your career when you look back, because these are some of the best patients to take care of, and practicing in oncology is certainly very rewarding for that reason. And that was true. And however, most of my career clinically after that probably primarily remained around cardiology, some retail medicine. And when I created the role I'm in now, it's supporting APPs that function, so PAs, nurse practitioners, that function in community oncology practices. They certainly are the oncology experts beyond me, but I think from a kind of business perspective, from a sponsorship or executive leadership perspective, I bring to the table those experiences I had in those other specialties. And I think overall, a PA, for the most part, regardless of what specialty they're in, the challenges are the same. When you're a new grad, when you're a new hire, when you're their first PA or their 10th PA, the challenges are very similar. How you manage those, how you navigate those are I think, the same.
I think you're going to be able to give a tremendous wealth of experience to our listeners. So I'm really, really excited. So let's dive right in, because I'm sure in the course of your career, you've hired and seen millions of different, probably thousands of different resumes and interviewed tons of different candidates. So let's start at the beginning. Let's start with that new grad resume, and then we'll kind of go out from there. But talk to me a little bit about what your process is when how you receive resumes, how you go through them, and how you make a decision as to who stands out and who you're going to actually engage in a conversation with.
Mm-hmm, sure. So, and I'll add that in my current role as the director of APP services, my job is really to support a number of practices. So these practices are still privately held private practices. And so what I do is support them and act as an adjunct when they're sourcing candidates. So I help draft the job description. I help them place the ad. We use placement services in some practices, or some communities have a hard time. I establish those relationships with PA programs that are local to those practices, and really try to get, which is very, very important, creating preceptor opportunities so that those PA students can be training in that practice, which is like a 1 month long interview where that APP or PA not only is learning the medicine and expanding on their physical exam skills and those types of things, they're also learning the staff, they're learning the electronic medical record, they're learning how to use Dragon for dictation. And so it's a perfect place to create your pool of candidates. And so I do a lot there for sure at the beginning, just to set up the practices to have these candidate pools that are easy to kind of pull from, and hopefully there's opportunity. And we'll help practices create opportunities when they have a good student. They'll think, well, we don't really need an APP now. And we can usually help them work that out and do some analysis in the background to say, well, there is some capacity. You have a physician that's going to be retiring soon. You have a potentially other site you want to open. I mean, there's usually some way to work around it. Also, just as an aside, the good thing about where I sit is that our practices are across the country. We have 40 private practices that make up our network. And so I could take a student that was training in one of our practices who maybe really doesn't have an opportunity, but if we find that's a good student that would probably become very good PA in oncology, we can find them a site somewhere else if they're open to relocation or moving across town or maybe even across the country. So we do a lot of that as well. But when we look at our candidates and so we hire, and I know because part of what I do is I support onboarding, which is, a huge challenge in community oncology. And it's a huge stress at the practice level to take a new grad who may not, and typically doesn't have any oncology background, and try to get them comfortable in community oncology. And you have to remember that in an academic oncology setting, PAs will typically get hired into a specialty specific clinic. So they'll see pancreatic cancer all the time. They'll see breast cancer all the time. In community oncology, you see whatever walks in the door. And so it's some benign disease, like anemias, all the way up to solid tumors like lung cancer and breast cancer, all randomly thrown in there. Plus the other services we can talk about in a moment on other ways that PAs in particular add value and add services to the practice. So so when the onboarding of that, the ramp up of that APP is extensive and can take a couple of years primarily before most of our PAs in that community setting, seeing anything that walks in the door, feel comfortable. It's tricky even for the oncologist to maintain knowledge as new drugs get updated and released and indications change and some indications go away. And we have to follow kind of pathways and guidelines on prescribing chemo and oral therapies. So I create kind of a centralized onboarding program from kind of my corporate view where we help provide some of that education. So in those courses, and we do 3 a year that live pre-COVID, went virtual during COVID, and then in a couple of weeks, we're going back live for the first time in a couple of years. And we're happy to see everybody come together. So it's about 100 APPs a year that attend this onboarding, what I call boot camp. And 90%, 85, 90% of those are brand new grads. This is their first job. So they're going to have to navigate not only how do I get into this kind of difficult specialty with a lot of drug names I can't pronounce and a lot of diseases and regimens and pathways, but also how do I navigate? I'm really a new PA. I'm not really 100% comfortable in my physical exam yet. I haven't seen everything, right? And so that's a big challenge. And so, but of the maybe 80% or 85% or so that are new grads, we get a handful that have that prior oncology experience. So it's not uncommon, and we do, to help this out, we do kind of motivate practices to think this way, is they have other staff in their office today that would likely be very good PAs. So there might be an infusion nurse, there might be some other paraprofessional that's already practicing or working in that practice, that we have some practices develop ways to help fund that education. Maybe it's a scholarship or a loan repayment program, and to train that person to come back then as a PA. And when we get that scenario happening, it's obviously a much easier transition with some challenges, because when you take an infusion nurse, for example, or a clinic-based nurse who's supporting providers in an office setting, and train them to become a PA, in some cases a nurse practitioner, that's their choice, and come back into the practice, there's usually the personality turf battles and things, because this was a person that, they were a nurse in that practice, they reported to a chief nurse or a charge nurse, now they're a provider, and it adds a little bit of some tension early on, works out obviously, but just adds some tension. So when I look at our new grads without the oncology experience, I think a lot of it comes down to that kind of the personality. We look a lot at the culture. So I get practices will reach out to me and say, I have these applications. None of them have oncology experience. There will be some that come from primary care and other specialties that have maybe a year or two under their belt, which certainly has some advantage. Just because they've seen some patients, they've practiced their history and physical exam skills more and longer. But primarily, we look at really that personality during the interview. So the resumes don't necessarily stand out on our new grads from my perspective.
The only thing I'm going to do, I'm going to stop you for a second, because what you're saying is like extremely valuable. And I love how you're talking about onboarding. But on the other hand, you are saying that you are bringing in a lot of new grads. And you must be getting tons and tons of resumes. So my only question is, there must be something. You're not interviewing everybody. So what are some of the things that for you will stand out on a resume? So you could separate one new grad from another, because you're obviously, if you get 1,000 resumes, you can't bring everybody in. So what's a point of the spear where that new grad resume goes into the let's interview this person pile versus let's maybe hold off on this other person?
I I think that's a good question. And I think that for me, when I see, and again, the practices individually are probably doing some screening at their level, at that kind of that site level. And then I might see, that stack that maybe they've already gone through. And you're right, a lot of, a new grad PA resume looks very similar to other new grad PA resumes. And I think one thing that helps for me from the thinking about building a PA in a community oncology setting is some of their prior experience, right? Before what they did in PA school potentially, but what they did before that. Did they have some interest? Did they do research, for example, when they were in their undergraduate program? Did they present in PA school during grand rounds on topics that are relevant to the oncology field? A lot of our PAs, and I mentioned research is a good topic, so a lot of our PAs become sub-investigators in clinical trials that we're managing in our practices. So you really can't provide cancer care without having access to clinical trials. And our PAs are vital in referring patients into that and following patients on clinical trials. And so those PAs that had that interest, which sometimes is a motivation for them to even pursue a career in oncology, they've done some work in college, whether undergrad or during PA school. That's very helpful because I know that person has kind of that mindset already on the importance of research.
Highlighting that on the resume so you can say, hey, this person has done research and it directly correlates to what we're doing. So that's someone I'm going to want to bring in.
Mm-hmm. I think if you think about oncology and the opportunities in oncology versus other specialties, we're not getting hundreds of applications for our jobs. So oncology is, and particularly probably in the community setting, for a lot of PAs, like when I go talk to senior PA students, only one or two might raise their hand when I ask, does anybody have an interest or thought about working in an oncology or hematology type setting? It's not a common specialty that PA students are thinking about. It's not very heavily taught. So the blueprint for PA education is very high level oncology lectures, and almost none of them get clinical exposure unless they're overlapping in their internal medicine rotation with somebody who also has cancer but is seeing the oncologist. Certainly those PA students that get an elective, that pursue the oncology exposure, right? Do electives in an oncology environment or setting, have that research background, that tells us, yeah, they're certainly interested and motivated for a career in oncology. Most of the students, if you think back to like a year one PA student who's just overwhelmed, just getting into the swing of being in PA school and thinking about why they wanted to be a PA in the first place, very few of them will say, I want to take care of cancer patients. Most PA students, I find, as they're learning the medicine, and initially you get more overwhelmed because you're just learning on top of learning. I teach at a PA school in Dallas now, and I teach a medicine course that you can just see the overwhelmingness, of the students, that as you keep adding material to them, a lot of them, and they hear, and we talk about cancer, and when we talk about our whatever topic. So for example, during our pulmonary block, we talked about lung cancer, but again at a fairly high level. But a lot of the epidemiology, a lot of the staging from a high level, but also the prognosis. And a lot of people just associate cancer with everyone's going to die, and it's a sad, depressing specialty. And why would I do that? And so the PA students that, for a number of reasons, whether they had their own experience with oncology, they've had a family member that had cancer, and they worked and dealt with the oncologist. They have that research background, whatever the case may be. Those are the people when we call that out, right? If they make that clear, and of course the personal experience would only come out probably during an interview. But I think that is a good candidate that we would say, yeah, this is someone we should definitely look at to meet in person.
Yeah, because I was going to ask that. You give some clear pathways for candidates, but what about the student who didn't do the research in college, and maybe they weren't able to land that specialty rotation, but they were with a great primary care doctor and saw some of those overlapping patients and really felt like inside, like, wow, this is something I think I'd like to explore and pursue. How does that candidate that may feel the drive internally get the access to an opportunity in oncology?
Mm-hmm. Yeah, so cover letter, I think would be probably the best way, so that if we can see the story and read that story on what that PA is looking for, what motivates them, what interests them. That's probably one of the more successful ways to do it. I don't know that would be just obvious looking at a resume. And a PA student's resume, depending on what they did in their prior lives. And back when I trained as a PA, it was a second career. So just about everyone I knew that was a PA in the 80s, 90s, already spent a number of years in a career and then went back to school. That's not the pattern anymore. So we have students coming out of undergrad, working a year or two to get medical exposure, often as a scribe, and then applying to PA school. So they don't have, their resume is whatever they did to get their medical exposure. So a lot, again, maybe worked as a tech, worked as a scribe, and then all the clinical kind of standard things that PAs would do when they're in PA school. And then fortunately, and hopefully then if they did land some of those specialty electives that show that this is where my interests are. But I think then creating that story, and I think having an opportunity to add to the resume with a cover letter that can describe.
So give me an example of something that would really stand out in a cover letter that might say to you, hey, before I even get to the resume, like, I know this is someone I'd like to talk with in person.
Yeah, I think it's particularly if someone has, that if someone who's pursuing a career in oncology, I want to know why, right? I want to know what was the trigger, what was the reason. And if they share personal experience, if they share that, they've had exposures to cancer in their personal lives, and how they saw how the PA interacted with the patient, which again could have been someone personal to them, or could have been them personally, and how they felt that the care team operated, functioned, how they took care of that patient, with compassion, keeping the patient in the center. You share decision making, all the kind of the buzzwords that we use today to really ensure that cancer care is equitable and appropriate and what the patient wants. And you can easily call that out, right, in a cover letter of describing kind of that background and where, what your interests are and where your interests are. And that would be someone that we would probably definitely want to talk to, because someone who's motivated and interested in oncology, going out of their way to tell their story, share their personal story, if that's what it is. I think that's a pretty successful opportunity.
I love that. So really, someone who might not have all the meat and potatoes to put in a standard resume format, telling their story in the cover letter and engaging you. So thank you. That's extremely, extremely valuable. So we're talking a lot about the resume and how to get your foot in the door. So now you've started an interview process with candidates. Tell me about your process when you're interviewing a candidate. What does it look like?
Sure. I mean, I like to, number one, hear from them, obviously, on why they chose a career in oncology, what they're looking for in working in this practice. Have they researched the practice and answer their questions about what might be just concerning to them about oncology. But again, I think people that are applying for oncology jobs aren't just applying because they need a job and it's a job opening near them. They really do have an interest, and so I just enjoy finding out what that is. What motivated that person to apply for a job in oncology, and since they don't have, we're talking new grads, you're not going to be able to ask them clinical questions. You're not going to be able to get a lot about how they would respond clinically, but you can get some personality kind of things checked off the list by asking how they would interact with a patient that's not happy that they're seeing a PA, or how would they interact with a coworker.
So what are you looking for in those instances?
Well, I think you hopefully that they can come up with some past experience where whether it was in high school or college or any of the jobs they had before PA school, and probably even during during PA school on clinicals, is how did they interact with peers? How do they interact with their supervising physicians? How do they interact with patients? And you can just try to get stories out of them, right? So tell me a time when you disagreed with a peer or disagreed with someone else in the office about a decision or a patient care choice. How did you interact? Tell me a time when you had to give bad news to a patient. How did you have that discussion?
And so, what are you looking for in their answer? What are they telling you that's making you feel like, oh, we're on the right track with this person?
Yeah, I think recognizing that things like emotional intelligence and the ability to have these challenging discussions and challenges within a practice. Obviously, we wouldn't expect a new grad to be able to be experts at that. But I think if someone has a positive spin on, yes, we had a challenge, there was a disagreement on a particular decision, whatever the case may be, or how I had to interact with a family or a patient and we had to provide bad news. I think it's someone that shows empathy, someone that shows kind of cultural humility. If the story goes down that road, did it turn into all kind of negative tones, or was it someone that gave a story where they thought, I'm putting myself in that person's shoes. I understand. We had a discussion. We sorted it out. I think what I try to focus on in our practices, and I help our practices individually do this, is really we find the candidate that kind of fits into that culture of the practice. Because each practice every practice probably has an undertone, right? And in oncology, it's very similar. I mean, it's stress. We want to know and let patients know that the days are going to be long. Medicine is not just 8 to 4. And so there's opportunities that you're going to be there late. There's going to be sick patients. There's going to be patients that are doing very well. There's going to be patients that we put into remission that, may do well, may not ultimately. And, having that person and that personality that can understand that and kind of match to that is very important.
Is there a point in the process, and again, we're talking on oncology specific, is there a point in the interview process where a candidate can exhibit too much emotion? Because it's an emotional, certainly more than lots of other specialties. Oncology, cancer treatment is emotionally charged. So is there a point in the interview where too much emotion, now that's not good?
Possibly. I'm trying to think back if I've ever really noticed that. I think that there have been candidates I've talked to, and some of them were just phone screening, some of them were face-to-face, or some were virtual like this, where they did have that personal story and kind of those emotions came out. And I think it's great that, and I think what the challenge for PAs in oncology is, you're going to come out of the exam room when you just gave bad news to a patient that you've been managing for a while, and that family very well, and they're all there in a family meeting, and you're telling them bad news, or you found out that they passed away in the hospital. You're going to have those days, or you're just going to want to go home and just sit by yourself and kind of recharge. And so I don't know if that would be necessarily a red flag. I think that what I worry about in some of and I don't know if I would be able to pick it up on an initial interview, but we certainly keep an eye on kind of the mental health of our PAs, particularly during the pandemic when we had higher burnout than normal, but it's a high burnout kind of a field working in oncology. And so we do try to keep an eye on that and provide any support as we can if we recognize it. But I don't know if I would call that out during an interview and be concerned that this person might be too emotional.
This wasn't part of what I was going to chat with you about, but it's just kind of really, really resonating with me. In a peek behind the curtain for students that are considering oncology, and you're talking about, coming out of a room where you're in and I've been on the other side, being in one of those family meetings what kind of support is there amongst the providers and the staff? Is it something that is spoken about? Is there, does the team come together and support one another to handle those emotions that they're going to be going through? I mean, we're human. That's why they got into that's why they got into the specialty to begin with.
Right.
Presumably.
No, definitely. I think there's kind of two schools. I mean, so a lot of our practices are, well established. They've been practices for some of them decades. A lot of the kind of senior staff kind of has that old school, don't show your emotions, and you put up the wall and you just kind of let those bad things kind of roll off. But I find that, and that, I mean, and I'm part of that generation from the, back when I trained, that we just learn, particularly if you're working in the emergency department, for example, where it's, this uncontrolled chaos all the time, and things can be very well and things can become very bad all of a sudden. And you just, you learn how to internalize a lot and move on to the next patient. And I think that today, the students that are graduating from PA school, have a little bit more, they're a little bit more vulnerable in that they're comfortable and more comfortable kind of sharing those emotions. And if they need to go cry in the hallway, they do it. And a lot of the staff is very supportive of that. So yeah, while there are going to be some personnel that will probably think, why is that person, visibly upset? It's just the nature of the job. I just think that there's nothing wrong with being able to, show your emotions, have the support. The staff around our PAs and our practices, whether it's a fellow PA, the nurses, medical assistants, our practices have social workers that certainly can help talk to our PAs. So yeah, I think it's overwhelming, and it's probably scary for a new PA to think, wait a minute, I should be impartial, and I should be in the room kind of just being a third party trying to, give you your medical advice and leave it there. But we are human, and it's certainly, okay to cry with your patients when they're crying during a family meeting when you're giving them news that they didn't want to hear.
Thank you for that. All right, let's kind of get back into, we were chatting about the interview process. You have a new grad sitting with you, interviewing. What types of questions should they be asking you during the process? What are you looking for?
Yeah, I think that's a good one. And I think they should really be clear on what the expectations are in their practice and what we expect, like our interpretation of a new grad, which is really a lot of what I do kind of as the consultant side of what I do to our practices, is to make sure that the practice is aware before they hire the PA on what this PA is going to be able to do on their first month, 6 months, 2 years, how we're going to ramp them up and train them. I think what a lot of PAs and our applicants, and a lot of times have had some exposure to oncology, whether they shadow one of the PAs in our offices, or maybe during school they had some opportunity. And a lot of them are coming in, these new grads are coming in, overwhelmed anyway. They have the interest in oncology, so that's the first big check. Like, we're happy that there's interest to practice in oncology. Then they recognize that in the community setting, they're going to have to learn a little bit about every disease and not just focus on one disease like they would in an academic center. And so there's a lot of overwhelming thoughts, and I share with practices a graph I put together that usually goes about 6 months from when a PA starts in a new role in oncology, and it's comparing kind of time to happiness. And so the happiness scale is high when the physician and the practice decide to hire the PA is excited to have the new job. And then because the expectations from the physician really didn't align with where that PA was from the clinical acumen, from just developing as a PA, the physician makes it more overwhelming for a new PA, who then feels like, well, I guess I should know this stuff, I guess, because they expect me to. I don't, because I've only been out of school a couple of weeks and I didn't learn a lot of oncology. but yet I'm new, and so I'm not going to say anything because I don't really, maybe it's me. And then the doc interprets that as, well, now I have a PA that's kind of shy and isn't standing up for themselves, so I'm not going to trust them anyway. And it just, the happiness scale just tanks. And about 6 months in, usually either the doc by then is saying, well, you can just, scribe for me, and we'll figure it out later.
How do you interrupt that when you see it coming?
Yeah, so we give, two things. One is we make sure that before practice adds a PA, that the physicians, in particular, the practice administration, kind of gets it better, but it's making sure that we level set what the physicians are expecting to get when they hire a new PA. And it's actually worse when we hire a PA or nurse practitioner that worked for them in the past as a nurse, typically, because that's a different beast. And so the docs will say, well, you were my infusion nurse, so you hung chemo and gave fluids and infusions all the time, and now you're a nurse practitioner or PA, and here's 20 patients to see. And they were never a provider when they were practicing as an infusion nurse. And so so just expectation. So from the physician practice facing side is education, right? This is what the PA is going to be able to do when they're out of school. Here's how we recommend you ramp them up, and we support them that way so they don't have to decide. If you leave it up to a busy doc, they're not going to be successful because they're just busy, which is probably why they're hiring a PA. And so they don't want the extra stress now figuring out how do I ramp up the PA. So that's where we come in, and that's where we educate the practice. Now the PA should have that education as well to be able to recognize that it's possible that as you navigate this role, and when I try to meet new PAs, which I don't always meet all of our new PAs right at their time of hire, but I'll meet them generally within the first several weeks of them being in the practice. We'll have that discussion and say, your job is to also keep an eye out on, do you feel like they're pressuring you to see more patients than you're comfortable with? Are you not ramping up like you think you should? Are you just continually scratching your head all day thinking, I don't understand any of this? Then they know they can reach out to me, and then we can put them on some other plan. We figure out how are they ramping them up. For example, in community oncology, we often have new PAs just focus on one or two disease. So they'll only see like colon and lung cancer patients, regardless of who else walks in the door, until they get comfortable with those diseases. And then we'll add diseases to them, or we'll have them focus on hematology for a while and not do the cancer care at all. And that, it slows the ramp up. And so from a busy kind of practice perspective, they're thinking, I have a provider, why can't we get them busy? But it's once we give them that education that it does take time. We need to ramp them up slowly so we don't hit that 6-month window where they feel completely overwhelmed. So I want those PAs when they're interviewing to kind of ask, what is the expectation, right? If I start day one, what's the onboarding process like? What type of education is there? So I mentioned my onboarding course. There's other societies that provide education. We would assign modules from those societies, like ASCO. Has an e-learning platform that has a bunch of modules on how to stage cancer, what's chemotherapy, what does supportive care look like in cancer care. And we give them that education, give them things to read at night, right? Precept still, act like a student still initially, see patients and present them in the hallway to the attending or to another APP. And we've also provide a competency framework so that our younger PAs, and we try to give this to them, I have practice as much as they can, give that to our new hires early so that they can see on paper what their career trajectory looks like. So they don't see or working with a PA that's been there 15 years, that knows everything about oncology, and to that new grad, that's just more overwhelming because I'm never going to get there, right? I'm never going to have that skill, that knowledge, and they will. And we've mapped it out for them so that they can see it on paper that this is where you're supposed to be in 0 to 6 months. And you're only going to see a couple of people, and you're going to keep learning. So I definitely want the PA that never asks, what support am I going to get, right? As from the clinic, what support is there from the physicians or other APPs? That would make me nervous, them not having that question. I would expect someone during an interview to be really clear on, look, this is like stressful medicine. This is complicated medicine. And how do I get supported as the new PA?
So let's talk about some of the red flags that I'm thinking about from both perspectives. So you have this unique experience. You have this wonderful onboarding program that you've created and that really is instilled in part of your, not only your interview process, but then when they arrive. So if a student is not coming to a practice in your network, what should some of the red flags What are some of the red flags that might come up for a student that they should pay particular attention to? Like, well, maybe this is not going to be the right fit for me if I take this position.
Yeah, I think that's good. I think anytime you're the first PA, and if you're a new grad in the first PA and they've never worked with a PA, and particularly if it's a smaller practice that maybe then we would assume probably doesn't have a ton of support, that would be very tricky. Not a red flag to run away, because as I mentioned earlier, I tended to land those jobs. But I think, would I have done that as my first job? Probably not, because you don't have the skill as a new APP or new PA to navigate that and to have some of that voice. You don't have that executive presence, if you will, yet as a new grad to help kind of drive. And you probably aren't even an expert yourself yet on kind of how do you get utilized well, right? What's top of license really mean? You may not even be aware of all the regulatory limitations that your state may impose on your PA practice. And so I think that would be cautious, and at least that would make me, if I was the applicant, to ask those questions on, okay, you've now had a PA, why do you want one, right? What types of things, and hopefully they already made that clear, but what types of things do you think I'll be doing as a PA? What kind of support will I be getting? What do the physicians feel? There's no other PA there just to help support, so there's no mentorship opportunity locally, but how are the physicians going to interact with me? What are some of those challenges? Why do they want a PA? And sometimes you'll get answers like, I hope that our practices wouldn't say this to an applicant, but I'll hear it kind of behind the scenes. They're like, the docs aren't getting their notes done. So to me, I'm thinking, okay, so you're hiring a PA to do their notes. And they'll say, well, I don't know. And then so we start in a discussion, and ultimately we might say, well, maybe you don't need a PA. Not that we certainly want to hire everyone we can, but we want to hire the PA to do the right things and not just, help the physician, finish a chart.
Understood.
So that would be important, I think, from the applicant side, being really clear. I remember when I interviewed for my first job, I was still in school, so I was nervous because I had to pass the boards. But I didn't want to not have a job. So I found a job, and it was that practice I said I was at for 10 years. I met with the owner of the practice, family physician, and I remember asking, I'm a new grad, so family practice has a lot of things come in the door in family practice, and what kind of support am I going to get? I asked the question, and what he said scared me, but he was joking. I found out later, but he's like, we're busy. We're not going to be available to every patient. We're going to expect you to come in and see patients. That was a red flag for me. And I went home and I talked to my family, and I was like, I really like this practice. I like this physician, but he's busy and he's not going to be there for me. And that makes me nervous. And so I didn't do anything more with that. I guess, looking back, I probably could have pushed a little more and said, give me an example of what that would look like. What if I did need support? And in reality, though, he was very supportive. The whole practice was supportive. But it definitely gave me some pause, and it just made me more anxious, if anything. So being clear during that interview, that while you're being interviewed as the student, you definitely should be asking questions on how this practice is going to support you, what their onboarding or training might look like. Obviously, a big win if there's already another PA there, because that person will naturally probably become that person's kind of mentor and help them develop. I think that's very important. And then probably even meeting that person, if you can during an interview, would be helpful as well. So from the employer side, I would think that the PA that doesn't ask any of that would make me think, I don't know if this PA is clear on what is going to happen when they start working. And I don't want a PA to just think, I'll let the punches roll where they roll to see if it's successful or not. Doesn't make me happy, right? So I would expect that PA from the employer side to be asking me, how are you going to support me? What are my expectations? What's the measure of success for me? And details around that, which I get, it's challenging because, again, a new grad doesn't have that knowledge base. They don't have that schema yet because they just came out of clinicals where they were told what to do and it was clear what they had to do. So it is a big challenge, but that would be a good lesson, I think, for those looking for a job in any field as the applicant, is to be really clear. And if they can't answer that question, if you're interviewing with a practice manager and they can't answer, I don't know how we're going to support you. That's a big red flag.
Yeah. So what does that tell you?
Well, I think that there's work to be done. I think that number one, practices should be better educated on the roles of a PA, why they're hiring a PA, not just because we want a PA. What I do in our network is, and it's not successful everywhere in our network, but what we try to focus on is practices should hire a PA from an organizational kind of top-down approach. So a practice should make a decision as a practice, meaning in a practice could have multiple sites, multiple physicians, even multiple specialties, but they should hire PAs from a top-down view and not a random physician who says, I need a PA, and then use a PA one way, and then their partner physician downtown in another site says, I also need a PA, and they use the PA completely different. And some of that's top of license, some of that isn't. And so I think having that structure in place, practices have that responsibility to make sure that they develop a program that's cohesive, that's organizationally driven, and has the support. They recognize what the PA is going to bring to them, and then being aware of that. And I think that's just education. And I feel bad for some of our smaller practices that before they joined us. So I do that support for our practices, but there are a lot of practices in oncology in the community setting that are not part of our network. And they don't have that. They don't have that support. So they never figure out, they wonder why they have turnover, but they never really figure out that the turnover is because we don't have a structure. We don't have a program where the APPs are part of that program. It's very hard as a PA. One thing that all PAs navigate is, how do you live in that gray space between being a nurse, and I was never a nurse, but I understand the nursing side. I know what that feels like in a practice, and a physician. And that gray area in the middle is a difficult place, a difficult lane to have to navigate in. And it's challenging for new PAs because they don't really have the expertise. They don't have their voice yet on kind of, how do I sell myself to stay in this lane, or how do I change that lane so now we're all providers and the PAs and the physicians are kind of lumped together. And in our practices, they still keep them very separate. And so that's a big challenge that I think PAs will have in their career, throughout their career. And it's not a bad thing. It's the role of recognizing that a care team is not a physician anymore.
So
right?
making
it's multiple
sure,
providers.
right. Yep. So for those physician assistants, when they're interviewing, to make sure that the practice they're going into knows why they're hiring a PA, has a structure for them so they could be successful.
Mm-hmm.
So we've talked a lot about the interview process so far, from receiving resumes all through, picking interviews and in moments of caution, maybe on either side. So now you've selected that PA out of your group of applicants that you want to make the offer to. Let's talk about compensation, and can a new grad negotiate an offer? What are your thoughts on that?
Yeah, that's a good one. And I'll add that a lot of new grads from the applicant side typically don't negotiate offers or benefits, which I think is also equally important, about total cash package as opposed to just base pay. And so what we do from the employer side, we'll talk about that first, is we really make sure that we keep an eye on our market data. So we're in a lot of markets, like 15 states right now. And so we either participate with data, survey type things like Sullivan-Cotter type programs, and really try to get the details as best as we can. We usually get down to the zip code on what the market value is for a PA. And that's not perfect, as you know, and so that's usually practice reported data, and it doesn't always have a ton of oncology call out or carve out, so there could be some challenges there. And then we never know the local challenge, and so there are hospitals in some of our communities that are really heavily recruiting PAs from our practices with a lot more money and a lot more incentive So I think if I'm looking at what we have a whole compensation team that we go out to our practices usually twice a year and say, look, here's the market value, here's where you're paying, here's your new grads, here's your senior APPs, you're below market a little bit, so you have opportunity to raise that up and try to get back into the market at least. Or if they're paying over market, then it's likely because they know locally that they're competing against a big hospital. So I think that, from a base pay perspective, I think our practices have those resources. A smaller practice may not have that resource. They'd have to either go find it on their own. Maybe they have other colleagues, other practices they can figure out like what the market values are. We also think from an employer side, APPs should be incentivized. There should be reward for work that you do. And a big challenge that all PAs should be aware of is that practices struggle regardless of the specialty, particularly if it's a subspecialty for sure, though. They struggle with valuing and valuating the value of the PA. They don't really understand kind of the financial piece of a PA, and they want to measure the value of the PA like they would a physician. But in oncology, and so, for example, in family practice, that would be appropriate because in family practice, the PA is very autonomous. They have typically their own panel of patients. In oncology, it's very typical for a lot of shared visits to occur where the physician and the APP might interact with that patient, but the physician will probably bill for it. And there's other additional services that improve the patient experience in their cancer trajectory that maybe isn't very lucrative for the PA to provide, but it does add value. And then when you think about value-based care and all the metrics that we get measured against that actually can lead to bonus payments and higher reimbursement, so there's value on the back end, initially on the APP spreadsheet doesn't look valuable. So my job is to make sure practices get that so they have a financial expectation on what a PA is going to bring to the practice as well. Now, PA students and PA applicants have the same obligation to research their value. And so with AAPA and other resources that does provide salary survey reports, they can figure out kind of what new grad average pay is, and they should have an idea to be able to at least come in there to have an idea. And as I said, a lot of our new grads usually just accept what they're offered because they want the new job. They're happy to have a new job. But every now and then we'll have a PA that will come in and say, oh, I need more time off. I need more CME budget. I want to have more days off to attend a conference. And that's good. And mostly when I see that happening, our practices are usually fine with that. I mean, they're usually not asking for anything that the practice probably wouldn't give them anyway.
So I'm hearing you say it's important and there's an opportunity there to negotiate beyond just the base compensation, but to negotiate on the benefit side as well.
Mm-hmm. Yes.
So what about a new grad that wants to negotiate compensation? Do they have a leg to stand on? And what could they tell a practice to implore them to maybe think about bumping up that base salary?
Yeah, I think if there's obviously, like we said earlier, doing their homework, doing their research on kind of what value is, I think that in medical oncology, unless that PA has a lot of experience in their past and is clear on the types of things that APP or PA is going to provide, they probably don't have a lot of background to be able to say, I'm going to ask for this salary because I'm going to be able to do this or provide this. A lot of the services that our PAs are providing, we teach them as once they hit the ground to provide. So things like advanced care planning, survivorship, we train our PAs to provide genetics. They're not taught genetics in PA school. And so for us to give them that extra training, we probably don't even really make it obvious in the interview that that's an option for them. And so I think that'd be tricky in a medical oncology specialty for the PA to be able to really voice, this is what I'm going to bring to you.
Right, because they're not coming in with some of those things that are very specific for oncology, whereas maybe if you were in the emergency room, you could maybe negotiate because you worked 10 years as an EMT.
Mm-hmm.
or what have you. So thank you for that. So I want to move on. I'm really excited to talk about the onboarding phase because your network is certainly so keen on that. So you have your person, you've made an offer, they've accepted, they've made it through the credentialing process, and they arrive to start their new career with you. What should those new hires, what shouldn't they be doing when they first come on board?
What shouldn't they be doing?
What shouldn't they be doing? And then we'll talk about what they should do.
Mm-hmm. I mean, they shouldn't be lazy. And so
what does that look like?
Well, I mean, if a PA is just going to kind of go through the motions, see patients with the physicians, not really take notes, because there's questions. The physician's like, okay, this patient has melanoma, and these are the things we worry about in melanoma. And if that PA doesn't go home and read on melanoma, then they'll miss it. They've missed that learning opportunity, and they'll have to wait for 3 or 4 more melanomas before they figure out, oh, that's what he was talking about. So what we try to tell our new hires is to do just that. So we say, look, I know you graduated from school. Congratulations, you passed your boards.
But you're still in school.
And you're still in school, and you're going to be taking notes, and you're going to be just attached to the hip. I try to tell the docs to make it kind of on their logic is treat this PA like your fellow. So have them go in the room by themselves, have them introduce themselves to the patient, have them do the history and physical, have them come out and present to you just like they did in school, just like your fellows did when you were in academics. And then you both go in and re-examine, re-eval, whatever the case may be. And you hope that PA, what I tell the PA then is make sure you have your notebook or your iPad or whatever you're doing and keep notes of, okay, go home and read that article, find that article on breast cancer, find that, whatever the case may be. So it's challenging if for the PA that's not motivated to really continue the learning process, if they just think I'm going to be complacent and just be happy because I have a job, then those are the PAs that the docs will then usually call me and say, this person is not catching on. They're not getting it.
Mm-hmm. What are some other things that maybe new hires should not be doing? And maybe it's in relation to, their interactions with their multidisciplinary team.
I mean, I think that in some of our practices, and we lay out a framework for practices to do this, but they don't have to do it, and so some don't do it, is if the PA is, sitting with the physician, seeing patients with the physician, but to your point, not really developing relationships with other people in that office or in that practice, then that's going to be a huge issue because, as we know, the physicians are not completely leading that practice, right? So a physician sees a patient or PA sees a patient and the patient needs a scan. Well, that can go now to maybe a scheduler, maybe a prior authorization person. Maybe there's a particular radiology center that they use that the PA doesn't know. There's a process that the PA needs to learn. And the PA can assume, this actually, I was just on the call before our call with the practice going through this exact same thing. The PA, new hire, assumed that they were going to give them everything. I'm going to give you all the knowledge of how to run in this, how to work in this practice. Well, of course that doesn't happen. But the PA never went out on their own to meet the pharmacists, to meet the social workers, to meet the patient navigators, to get a relationship going, right? How can I help you? And particularly if you're the first PA, those other people, other specialists, paraprofessionals, they don't know what you're doing there either. And so I think they need to be able to be accessible to the staff and develop those relationships, introduce themselves. And we have a model where we have practices, if they follow it, we say, okay, in week 1, have them sit with your your patient financial counselor, your front desk, your lab, just so they see those processes.
So those are some really good advice on the flip side of what to do. So when you have that hire, how do you know, what's going on behind the scenes that make everybody feel like, yeah, this person was a good hire? What's that PA doing?
Yeah, I think they're asking questions, right? They're learning, and you can see the light bulbs, going off on the PA's face, that they're paying attention, they're learning, they're asking questions, they're participating, they're non-confrontational. There's no stress when the nurses come to them, the MAs come to them with questions. Or vice versa, there's interaction there. There's that learning environment. And so I think if you can tell the PA that sees patients, goes, sits in their office and really doesn't participate, doesn't ask questions, we don't know really how they're doing unless we physically try to check in with them. And then when we try to do that to say, how's it going? We want to support you as your new hire. This is your first job. And then sometimes things will come out where they'll be honest about, well, I don't really feel like I'm seeing enough patients or I'm seeing too many patients, but they just didn't have that voice to make that clear to the practice. So I think that would be, something that I would be concerned about, but I would still can be fixable. It's still where we can sit down with that physician, with that clinical director, with that PA and say, look, here's how, we can maybe reshape the direction that you're going with this PA so their onboarding is a little more fruitful for them.
Understood. I want to spend a little bit of time talking about the M word, and that M word is mistake. I want to talk a little bit about, because they're going to happen, right? Mm-hmm. Your new providers at some point are going to make that first mistake. Talk to me about what that looks like, how it should be handled, and maybe some of the failures and successes you've seen in your years of doing this.
Mm-hmm, sure. Yeah, we definitely want honesty. We want to create a culture where a PA could come out or whatever the case may be, have that discussion, whatever scenario it is, with their supervising physician or peers or clinical director and say, yeah, I made the wrong call. I prescribed the wrong therapy. I misinterpreted, a lab test and their, patient had a reaction. And so we want to have that. We don't want the culture to be where, we don't share that information and then that PA just loses that ability to be honest, I think, from then on, if they're just going to kind of cover it up or sweep it under the rug. And so I think in oncology, it's most of the time in my practice, in my experience, I think that our practices are set up pretty well there. I mean, they do want the open communication. They want the staff to be honest. I remember back when I was in family practice, we had an MA that was pretty new as a medical assistant, and we gave allergy shots to our patients because the allergist was too busy to do it. And so the allergist would ship the serum to us and patients would come in for their shots. And the medical assistant typically would give them their dose, their immunotherapy, and they would sit in our lobby for 20 minutes or so to make sure there was no reaction. And so this new MA gave a patient like 100 times what the dose should have been, like misinterpreted a decimal point. And she came right over. She could have not said anything. And nothing happened to the patient. As a matter of fact, when we did call the allergist, he said, did anything happen? And we said, no, he tolerated it fine. He's like, well, good, he's cured. I mean, you gave him so much of that exposure. He didn't have anaphylaxis. I'm like, no, he's good. So, but she came right over and the nursing manager wanted to fire her. And I said, certainly not. I said, we all make mistakes. We all misread things. She didn't wake up that morning and say, I'm going to make a mistake today or on purpose. And she came right over to me immediately and said, Jason, I'm sorry, but I just did this. And we watched the guy, we brought him back, we put him on a monitor, he was fine. But so that's the culture that we want. And like firing her would have told everyone else in that office, we're not honest, we make a mistake. So I think in our practice in oncology, because the patients are critical, some of our like acute lymphomas, acute leukemias, they're in the ICU sometimes for a week or more. They're critical. It's very high stress. There's going to be mistakes. You're going to misinterpret something. You're going to read something incorrectly. We have checks and balances like anything as much as we can, but we want the PAs to learn. Just like we all are going to make mistakes. We want them to just accept that it's a mistake and then learn.
So, Jason, you've given us such amazing information today, but I want to end our talk with a question for you. I am now your career genie, and I'm going to put you back to when you were graduating PA school. You've had amazing experience. You've learned so much over the years. If you could be a little birdie in your ear all those years ago, what advice would you give yourself that you think would have made all the difference for you today?
Yeah, it's good. My first whisper would be, you chose the right career. right? So if I could sit back, 25, 26 years ago, looking where I am now, then I'd be super satisfied back then that I chose the PA route and trained to be a PA. And I think beyond that, in addition to that, I would certainly want that advice, like we talked about all morning, is, what are you going to be doing in this practice? What kind of support is there in this practice? How do they measure success and value in this practice? Are you going to be treated as part of the team and be accepted as a PA? Is the community accepting of PAs? Is this practice accepting of PAs? And I think that, and I fortunately, besides that very short episode where my future boss in my first interview said, I'm not going to be here to help you, I'm not going to support you, which was a lie. Beyond that, when I hit the ground on day one, and of course I was completely scared because of what he said, and as soon as I showed up at work, we had workstations in the hallway by our exam rooms. He had mine right next to his. He was completely available and completely there to train for the whole time I was there. So I think having expectations, having realistic expectations, you're going to be nervous. You're not going to know exactly what's going to happen. But I think having the support, having a practice that's happy that you're there and supportive that you're there, I think is key. But it's the best career move. I don't know any PA I don't know any PA that years later, practicing in multiple specialties, practicing in administrative medicine like I do now, is wondering or second guessing, why they chose the career.
Thank you. Thank you so much for being here with us today.
Yeah, you're welcome. I appreciate the time.